Welcome to Thinking in Psychiatry, an Academy by Psych podcast, where we distill new research, translate evidence into practice, and support clinical decision-making for busy clinicians. I'm Dr. Sanil Rege, consultant psychiatrist and content curator at the Academy by Psych. Today, I want to look at a paper that has already generated strong reactions in our field. It's the KARMA-Dep 2 trial, published in JAMA Psychiatry in October 2025, titled Serial Ketamine Infusions as Adjunctive Therapy to Inpatient Care for Depression. If you've seen the headlines state, well, ketamine failed. It was no better than Midazolam. But I want to take a different angle, a clinically relevant angle. The question is, did ketamine really fail? Or are we asking the wrong question? Because once we look at the curves, rather than just the p-values, the story becomes less about ketamine versus midazolam, but more about how we think about psychiatry as a whole, but more importantly, how we think about rapid change, neuroplasticity, and recovery in psychiatry. So let's start off by setting the scene. We know that ketamine has been positioned as the rapid-acting antidepressant. And we're entering a field of neuromodulation and rapid-acting treatment. Intravenous ketamine, esketamine nasal spray, and accelerated neuromodulation protocols all have the same narrative: faster relief for people who've been stuck for years. And that's a good thing. At the same time, off-label ketamine use has exploded, often ahead of the evidence. So linking it to real-world context where we actually practice becomes very important. So JAMA Network KARMA-Dep 2 study is important because it asks a very straightforward question in a very pragmatic setting. If I add serial ketamine infusions to usual inpatient care for moderate to severe depression, do I get a clinically meaningful advantage over a psychoactive comparator, in this case, midazolam? On the face of it, according to the study, the answer is no. But if we stop there, we miss the clinical lesson that is hiding in plain sight. So let's look at the study design. What did this study actually do? This was an investigator-led, double-blind, randomized controlled trial conducted at an academic hospital in Dublin between 2021 and 2024. Patients were randomized 1:1 to ketamine or midazolam. Ketamine dose at 0.5 milligrams per kilogram IV over 40 minutes. Midazolam at 0.045 milligram per kilogram IV over 40 minutes as an active comparator. Infusions were given up to twice weekly for a maximum of 8 sessions, all during the inpatient admission. And I wanted to just keep this fact in mind that this was during an inpatient admission. Crucially, this was adjunctive treatment. So usual inpatient care continued: antidepressants and mood stabilizers, antipsychotic, nursing input, OT, etc. The primary outcome was change in MADRS score from baseline to end of treatment, defined as 24 hours after the final infusion. Of course, they had other secondary measures as well. The total numbers, we're looking at 65 participants were randomized. 32 in the ketamine arm, 30 in the midazolam arm, total in the final analysis. The main result is straightforward. After adjusting for baseline severity, there were no statistically significant difference in end-of-treatment MADRS scores between ketamine and midazolam. There were also no between-group differences in cognition, quality of life, or cost-effectiveness. Safety was broadly similar, with expected dissociation and blood pressure changes in the ketamine arm, with more marked sedation with midazolam. Finally, and this is important, most patients and raters accurately guessed treatment allocation as the trial progressed, so functional unblinding was substantial. If we stop here, it sounds like a negative trial. But it's when we look at the shape of the curves, the more interesting story emerges, as you can see here. Have a look at the curves. This is the wow effect. If we examine the MADRS and QIDS trajectories across infusions, we see the following pattern. So if we examine the MADRS curve and the QIDS trajectories, what we can see is that both groups show a steep early decline in depressive symptoms from baseline through the infusion phase. So we can see until 6 weeks here, and here. After that, the lines flatten and track together from 6 to 24 weeks with overlapping confidence intervals. In other words, everybody improves early. Then the pace of change slows. The separation between ketamine and midazolam is modest, and by later follow-up, the curves have essentially converged. Clinically, this is the familiar wow effect that we all recognize. Doctor, this is life-changing. My anxiety vanished. I can think clearly. And we know that this doesn't just happen with ketamine. It happens with benzodiazepines in relation to anxiety. It happens with stimulants in the context of ADHD, antidepressants even. We hear those phrases with ketamine, ECT, intensive neuromodulation, benzodiazepine, in the right context. That early drop is real, but it's not unique to ketamine. Remember what midazolam is doing here. It's not simply a inert pharmacological agent. It's a psychoactive comparator that reduces arousal and anxiety, and it's being delivered in a highly structured, contained inpatient environment. So what KARMA-Dep 2 trial is telling us is not simply that ketamine failed. It's actually telling us that in a hospitalized population with comprehensive usual care and a psychoactive benzodiazepine comparator, the extra symptomatic advantage of serial ketamine infusions is small and is hard to distinguish from non-specific effects. So this brings us to the important question. Why does improvement stall? This is about response versus recovery, two different constructs. And this is shown when we looked at the curves flattening. Why do we see this burst of early change and then a plateau? Part of the answer is built into the outcome measures. You see, MADRS and QIDS SR16 are primarily symptom scales. They're sensitive to short-term shifts in mood, sleep, appetite, anxiety, negative cognitions, etc. But they're much less sensitive to sustained changes in function, role performance, motivation, executive capacity. And we know, for example, in depression, it's the residual cognitive symptoms that pose the largest burden, that are linked to functional outcomes. And this is covered in the quality improvement project, the quality improvement audit that we have on the Academy on cognition in depression. So what that means is patients can look better on paper, yet still unable to work, plan, initiate, or connect because cognition, motivation, and executive functioning have not caught up. We see the same pattern in other rapid-acting interventions. So take modern ECT series and reviews. Relapse rates after successful treatment are about 37 to 38% at 6 months and around 51% at 12 months, even with continuation pharmacotherapy. So we know that ECT can produce dramatic responses in the right patient. In psychotic depression, we have response rates anywhere between 85% to 95%. But relapse, about 50% may relapse after. Similarly, in more recent work on Stanford neuromodulation therapy, very high remission rates at 1 week, 70%, but only 1/3 remain in remission at 12 weeks. Roughly half of initial remitters lose benefit over 3 months. So this signature is consistent in psychiatry if we think of it. We see this. Rapid action does not automatically translate into sustainable recovery. From a neuroscience perspective, that makes complete sense because ketamine produces an acute glutamatergic surge. It's an NMD antagonist, BDNF release, transient increase in synaptic plasticity, particularly in prefrontal limbic circuits. That's the response phase. The brain's window for learning has opened up. But recovery is a different phase. Recovery requires neuroadaptation because the brain is an organ of prediction. The brain is neuroplastic. And what it's looking to do is to consolidate, stabilize, and integrate new patterns of thinking, behaving, and relating. And that's a really individual process. That process is a learning process. It's about routines, goals, relationships, effort allocation, sleep, and connection to the environment with environmental feedback. So the brain is not built to sit in wow mode. It's built to ask or convert wow into what now? So it's constantly updating predictions about the world to minimize surprise. If the environment does not change in a way that reinforces new patterns, the system will drift back towards its prior predictions. And the same predictions are what kept the individual stuck. So without that change, the early response moves to what looks like stalling. Clinically, that looks like, well, it worked, but now it's not working. And we narrow down our frame to ketamine's lost effect. There is more to it than just ketamine or stimulant losing effect. So with that, let's come to the clinical implications. How should we practice differently? Because that's the aim of the Thinking in Psychiatry podcast. First, I would avoid the simplistic interpretation that ketamine doesn't work. Meta-analysis still show clinically relevant effects compared with saline, particularly in outpatient treatment-resistant populations, although effect sizes shrink when midazolam is used as a comparator. What KARMA-Dep 2 tells us is more specific. 1. In hospitalized adults with moderate to severe depression receiving comprehensive inpatient care, serial adjunctive ketamine infusions do not produce a large or clearly sustainable symptomatic advantage over a psychoactive benzodiazepine. The effect, if present, is small and may not justify routine use in this setting. 2. Inpatient admission itself is a powerful intervention. Structure, safety, relational containment, and removal from adverse environments likely account for a substantial proportion of early symptom change. The wow may be more about where the patient is than what they're given. And this brings me to the Academy course by Professor Michael Berk, where he talks about aggregation and marginal gains. When we think about improvement, it's not about one single entity providing the complete environment. It's rather the compounding effect of multiple 1% gains from different strategies: psychosocial, psychotherapy, inpatient admission, medication, diet, lifestyle, etc. The third point is, if we're going to use ketamine, we should stop thinking of it as a standalone antidepressant and start thinking of it as a plasticity opener, a medication that opens up a window for neuroadaptation, as all pharmacology should be thought about that way, or psychopharmacology should be thought about that way. And it needs a structure or a program to be built around it. Practically, that means setting expectations, predictions, pairing treatment with structured behavioral activation, skills-based psychotherapy, the targeted psychotherapy that the patient needs, family systems work, rather than treating them as isolated pharmacological events. And then measuring what matters, not simply symptom resolution through MADRS, QIDS, but rather connecting it to functional and cognitive targets, work capacity planning, social engagement, initiation. And as Academy members, you'll know that when we think about improving cognition, to think is to move. So we connect that to movement. Similarly, the word emotion links to movement, arousal, connected to activity. And those are our functional targets. So therefore, it means being clear about who this is not for. Ketamine is not a routine first-line medication for hospitalized patients with depression. Cardiovascular risk, substance use, psychosis risk, capacity to engage in structured follow-up plan all remain important boundaries. So let me pull all of this together into our clinical pearls and key takeaways. First, rapid early improvement in depression scores, whether with ketamine, midazolam, ECT, or neuromodulation, is often a non-specific signature of combined biological and contextual change. The wow at day 3 or day 7 does not tell us whether the patient will be functioning 3 months later. Second, the neurobiology of response is not equal to the neurobiology of recovery. Ketamine-induced neuroplasticity is a window of opportunity, not a guarantee of sustainable change. Without deliberate behavioral, psychological, and environmental scaffolding, the brain will drift back to its old predictions. Third, our measurement tools shape our conclusions. If we only measure symptoms, we will continue to misread short-term shifts as long-term solutions and underestimate the importance of cognition, motivation, and role functioning. So the key decision-making takeaway for us here is to move away from does ketamine beat midazolam and madras at the end of treatment to asking how can we integrate rapid-acting interventions into a recovery-oriented framework that links short-term plasticity to long-term functional adaptation. Thanks for listening. You can find links to the paper and related Academy modules on your dashboard. I'm Dr. Sanil Rege, and this is Thinking in Psychiatry, where how we think is just as important as what we prescribe. Until next time, keep thinking carefully and thinking clinically. Bye-bye.